Our topic for today is all about the study of risk factors and causation. Now, this is the last topic for your prelim coverage, and this is actually divided into two parts. So expect that there will be two video lectures that will be posted on Canvas. The first part is more on theories. The second part, expect that there will be computations. Now, as to this topic, with regards to the study of risk factors and causation, as an epidemiologist, we are actually frequently involved in studying to determine causation. And when we talk about causation, from the root word meaning cause, so that is to find the specific cause or causes of a disease. Now, as to the objectives, so this will be our objectives to explain the concepts of cause and what are the different types of causal relationship, understand the different types of causal and non-causal associations, identify what are the different guidelines in judging whether an observed association is causal, and then recognize and explain the common pitfalls in causal research. Now, for each types that will be discussed, or even in the guidelines, or even in the common pitfalls, we'll try to relate it to your uh, in real life situation and to some examples of diseases. So to start, a causal relationship actually asks two questions, and that is first, as you can see here, in terms of this part, the first question would be, do we observe an association between exposure and disease? Now, once we have observed an association, your next question would be this one, in which we tend to ask that if that observed association between exposure and disease is actually causal. And this is what causal relationship is all about. We try to determine whether there is an association or correlation between an exposure or characteristic and the risk of the disease. So now we go to the different types of causal relationship. Now to further explain what is causal relationship, it is actually the correlation between two events. What are these events? It could be from an exposure and then ending up to a certain disease or outcome. So causality refers to the idea that one event, behavior, it could be a belief or it could be a variable, will result in the occurrence of another or subsequent event or another variable or another behavior. So in other words, it is just about the cause and effect. Now, there are actually four different types of causal relationship. One is the necessary and sufficient causal relationship or necessary and sufficient cause. Second, necessary but not sufficient. Third, sufficient but not necessary. And lastly, neither sufficient nor necessary. Now, to understand better these four types, let us define first what is necessary and what is this sufficient. So starting with sufficient cause. Now, sufficient cause is it means that if the cause is present, the disease will always occur. Whereas for the necessary cause, the cause must be present for the disease to occur, although it does not always result in the disease. Now, remember the definition of this one, since kanimanggod na definition with regards to sufficient and necessary would make you understand better as to what are those four types of causal relationship. So let us start with the necessary and sufficient. Now, necessary and sufficient, it means that without the factor, the disease will never develop, and in the presence of that factor, the disease will always develop. So, the first definition is actually referring to necessary, and the other is actually referring to sufficient. Now, basically, this type of causal relationship is actually very rare, but let me try to give you some examples of this one. So, one example is your infectious diseases, in which a number of people are exposed, some of whom will manifest the disease and others who will not. And this is actually the design of the necessary and sufficient. Diba? Factor A is both necessary and sufficient and would really come up with the disease. So one example for this is tuberculosis. Diba? In terms of tuberculosis, we have the causative agent, your Mycobacterium tuberculosis. But basically, if naa kay TB, and then, of course, namo sa isa ka balay, kauban ang imuhang family, members dara sa inyong household, di ba, they do not uniformly acquire the disease from the person with tuberculosis. Meaning that Mycobacterium tuberculosis, although being a causative agent, then we could say that it is a sufficient cause. Kaya diba, as defined, the presence of this factor, we would expect the disease would always develop. But then again, namagoy cases na even if na ay nakuha nimo ng Mycobacterium tuberculosis na agent, magdepende man pud gud na siya sa kung uns ang burden or unsa ang dosage na makuha jud pud nimo ang signs and symptoms. And not all the time that even if you harbor that certain pathogen, dili po jud always na magdevelop pud gyud ka sa imuhang tuberculosis. And that actually explains the necessary cause. Diba? As defined, necessary cause is without the factor, the disease never develops. So, magmatter na lang yun siya actually kay sa person na involved or na-expose since dili man gyud ta same in terms of immune status, in terms of genetic susceptibility. So that is why, as mentioned, it is really or this situation that a certain factor is necessary and sufficient, grabe gyud lang siya ka-rare. Next would be necessary but not sufficient. Now, necessary but not sufficient, actually we are trying to look at multiple factors here. So that is why as you can see, multiple factors are required and it is often in a specific temporal sequence. Now, an example for this is carcinogenesis. Carcinogenesis is a multi-stage process involving both initiation and promotion. Now, for cancer to result, a promoter must act after an initiator has acted. Dili pwede na ah, mauna ang promotion bago ang initiation, and dili pud makakos og carcinogenesis or dili pud makakos og cancer rather if initiation lang ang naa and if promotion lang ang naa. So that is what necessary but not sufficient causal relationship is all about. Kumbaga, kaya na-mention kanina na multiple factors because each of these factors is necessary, each of these factors should be present in order for your disease to occur. So, try to look at our design here. Diba? Design sa itong necessary but not sufficient na kay factor A dapat, and then after, dapat na din si factor B mag-proceed, and then si factor C. Collectively, kung present ni silang tulo, then that would really result to your disease. Next is your sufficient but not necessary. Now, the factor alone can produce the disease, but so can other factors that are acting alone. So an example for this is radiation exposure and benzene exposure in terms of causing leukemia. Kumbaga, sa isa ka disease, diba, daghan magyud ta og factors na pwede na makakose sa iya ha. Na in terms of leukemia, dili necessary na dapat ma-expose po ka sa radiation and ma-expose po ka sa benzene in order to get leukemia. Kaya siya ginatawag na sufficient but necessary because even isa lang, ani sa duha, that could already cause leukemia. So, kunwari, radiation exposure lang, it would still end up with a disease. Or kunwari, benzene exposure lang, it would still end up with a disease. And think about it this way. What if naa ka both? Then all the more it will increase the probability of you getting leukemia. Next is neither necessary nor sufficient. Now, a factor by itself is neither sufficient nor necessary to produce a disease. And an example for this are CHD. Most chronic diseases like CHD means your coronary heart disease. So, unsa day ang naaaning sa CHD? Let us look at the design of your neither necessary nor sufficient. Kumbaga, daghan siya og factors but in a different combinations in order for the disease to occur. Diba? If you try to look at per box there is inyong design, so kani si factor A and factor B, it could lead to the disease. Si factor C and si factor D, which is another type of factor, could still lead to the disease. Si factor E and si factor F, again, another set of factors could still cause the disease. And that is why it is neither necessary nor sufficient. So, to give you a concrete example, pagyud, this one. So, this is actually an example, again, specific na ni siya na example as to how CHD will develop in the individual. So, mo ni siya katong kaganina na nagidungagan na lang yun nato ni siya og specific na factor. So, this one, si factor A, it is composed of your diabetes, high LDL levels, and genetic susceptibility, of which, of course, combined together, that would cause your CHD. Another factor that we are trying to look at is smoking, low HDL levels, physical inactivity, and arterial hypertension. And for this set of factors, diba, if you can see, different but still even kanisha, that it will still cause your CHD. So that is why it is neither necessary nor sufficient. Actually, pwede na ito ma-example po diri ang smoking. Smoking and lung cancer. Now, ngano ba consider as neither necessary nor sufficient sa smoking? Smoking is not a sufficient cause by itself because, diba, dili man gyud tanan smokers mag-develop og lung cancer. Now, smoking is also not a necessary cause because na ay small fraction, diba, dili man tanan pud na nagka-lung cancer kay naga-smoke. Diba, we have that such thing as secondhand smoking. So that is another example of this causal relationship, neither necessary nor sufficient. So now we go to your causal and non-causal relationships. Going back, just to further explain, the first and most basic requirement for causal relationship to exist is that there should be an association, of course, between your outcome of interest and the presumed cause. Now, the outcome must occur either significantly more often or significantly less often in individuals who are exposed to the presumed cause than in individuals who are not exposed. Siyempre, para makonclude yun nato na cause siya, dapat dili yun kaayo na siya nag-occur dito sa dili exposed. And exposure to the presumed cause must make a difference. If walay difference, then technically speaking, it is not the cause. Now there are, I think, four types of causal and non-causal association. First is your directly causal association. Now, this means that the cause exerts its effect in the absence of intermediary factors or intervening variable. When we say intermediary factors or intervening variables, this actually refers to the factor that is linking the the factor that is linking to the cause and or the factor to your outcome or from your exposure to your outcome. Now, from the word direct, meaning siya agad-agad ang nakakause sa imuhang outcome. So, one example for this is, kunwari brain damage, di ba? If ang kanina certain individual gikulata og taman kumbaga and then naigo iyang hulo and because of that severe blow to the head, nagka brain damage or worst case scenario, it leads to his death. And di ba, from that example, napa ba may other intermediary factors or intervening variables? Di ba wala? Katong pagkaigo mismo sa iyang ulo, mao to exactly and directly causing his brain damage. Next is indirectly causal association. Now, indirectly causal association means that the cause exerts its effect through intermediary factors. Now, this time around natin nagalink na kung ano, kanina certain exposure or kanina certain factor, nakakause ani na outcome. Now, an indirect causal relationship is said to exist if one condition has an effect upon an intermediary factor and in turn increases the likelihood of developing the second condition. An example of an indirectly causal association is in terms of poverty. Poverty and its increase of chances of getting disease or mas prone sila as to death. Diba? Poverty is not the direct cause. Diba? Dili man pasabot na tungod pobre ka, agad-agad jud ka na mamatay. But then again, if we try to look at the intermediary factors involving poverty, like for example, syempre poor ang health, kay wala may money. So, in short, the cause of the poor health, kay walay kwarta, so meaning inadequate na dayon ang nutrition, kay walay proper feeding, walay proper food na ginakaon, and then improper na housing, walay tarong na medical care na mahitabo in terms of kanang kung magkasakit man, dili agad-agad na makapa-check up or makapa-hospital, then that is your intermediary factors. So that is why poverty could cause disease and death. Next is your non-causal association. So kanina from the word itself, non-causal. Now, statistical association between a characteristic or variable of interest and a disease due to the presence of another factor, known or unknown, that is common to both the characteristic and the disease. Now, the third factor that we are actually referring here is what we call confounding. But in terms of confounding, we will discuss that later further. So going back to your non-causal, uh, let me give you an example. Patients who have coronary artery disease, commonly ma-observed sa mga tao na naingana na sakit is upaw sila or there's baldness. But if you try to look at, baldness does not actually cause the coronary artery disease that the patient has. Pero, associated lang siya, it's because the other problem or factors involved as to getting a link between these two, between baldness and CAD, it could be due to age, gender, or we could actually look at the dihydrotestosterone level. Diba? Kaning coronary artery disease, grabe siya ka-common good as we age. And it is the same with baldness na as naga-age na, diba, naganipis man yun ang ato ang buhok. So that is non-causal. Baldness is associated with the risk of coronary artery disease, but baldness in itself does not cause your coronary artery disease. Next is your bidirectional causation. Now, bidirectional causation means that each of the two variables may reciprocally influence the other. So, kumbaga, kung ato na siyang state another way around, A causes B and B causes A. So, mo na reciprocally influencing the other. So, one example here is physical activity and your body mass index. Siyempre, the more you increase your physical activity, the lower your body mass index would be. But then again, if you try to look at kung ato na siyang i-reverse, diba katumang yung mga naapoy baba, the body mass index, sila man yun na ang naapoy increase na physical activity. So there is a reciprocal na relationship between these two. Try to observe ang katong mga obese na patient or katong mga not to offend pero katong mga dagkuon gyud kay na mga tao, 'di ba? Because they have a large or high body mass index, the tendency is dili kay sila kapuyan. And since dili man kay sila kapuyan, then there is lesser physical activity that they are doing. So mo na ginatawag nato og bidirectional causation. Again, the more na gina-increase nimo imong physical activity, the more na nagalow imong body mass index. Other way around, the more na low imong body mass index, the more po na naga-increase imong physical activity. Then there is a reciprocal relationship. So now we go to the guidelines for judging whether an observed association is causal. Siyempre, di ba, manaman ta ato sa ato ang first na question na ang na-observe, na naabatay na observe na association. If na-observe na association, then we need to know if causal ba ang relationship atong na-observe na association. So in order for us to judge or to really answer that question, we need to look at this 9 criteria in judging if your observed association is causal. So we'll discuss each of this one, from your temporal relationship to the strength of your association until specificity of the association. So isa-isahon nato na siya. Let us start with your temporal relationship. Now, when we say temporal, this actually refers to time. And to show causation, the suspected causal factor must have occurred or been present before the effect or before the disease have developed. Now, if you try to read this line, this is actually very common sense na kumbaga, by the time na nagkasakit ka or by the time na nakuha nimo ni na certain na disease, if na kay nakita na exposure or factor, pero dara pa nimo siya na-observe after na develop pa nimo ang disease, then automatic yun na siya, dili yun na siya mao. Kina naman ka ato na disease, nga no i-consider pa man to nimo na certain factor. So that is why temporal relationship is actually very important for us to be able to conclude that the observed association is causal. Now, with chronic diseases, the timing of the exposure to the risk factor and onset of the effect of the chronic disease is often unclear. Diba? For example, if you have cancer, when did that cell become cancerous? Or if naay na form na kidney stones, kano sa man siya first na na-form? Or when did your atherosclerosis began? So, mo siya mga certain questions na ato ang dapat pangutan-on with regards to chronic diseases. Likewise, the onset of the risk factor may also be unclear. Diba? When did the blood pressure begin to increase? When did the diet first become unhealthy? So, kana po ng mga certain question kay magdepende mong po guna. Like, for example, ikaw di ay dugay na di kataas og BP, pero recently lang ka nagpa-check. Then, medyo na ay inaccuracy man gud kung ato na ding automatic na i-assume na kana lang yun po to na time. Now, in terms of the latent periods and incubation periods, temporal relationship here may also be obscured because these latent periods and incubation periods varying ang iyahang time and then in range pag yun na siya. Now, let us define first what is latent period and what is this incubation period. When we say latent period, this is the period between infection with a virus or other microorganisms but wala pa'y signs and symptoms ani na stage. Kumbaga, murag nakuha pa lang nimo or present na si pathogen pero wala pa ang infection, dili pa makita. As to the incubation period, this is the period between exposure and onset of clinical symptoms. Now, latent period and incubation period, again, varying kaayo ni siya. Let us take for example, parehas ani 'di ba kay COVID, na we need to wait for at least 7 to 14 days before na naagid tay na para mag-observe ta is naanay presence of signs and symptoms. Or kato si HIV, kato kong giingon, 'di ba sa HIV uban na months pa lang, 6 months at most, nanay ka nang makita ng mga signs and symptoms. But sometimes, a certain individual, dira pa mag-appear until pila pa ka years after, kaya magdepende mo po na sa body. So that is why, as mentioned here, diba, temporal relationship may be obscured because of the variation of the latent period and incubation period of such diseases. Next is the strength of association. Now, the strength of association is actually measured by the relative risk or odds ratio. Now, dili lang sana ko i-discuss further what is relative risk or odds ratio because this too is actually part sa computation na inyuhang na atuang i-discuss sa second part sa atuang video lecture. Now, just remember that the stronger the association, the more likely it is that the relation is causal. Siyempre, in terms of strength of association, dapat naman yun na proper measurement ani in numbers na makita. Dili man pwede na moingon-ingon lang ta na, kani, okay na gyud ni siya. So, unsa siya ka okay? Unsa ka kusog ang association na present ana sa ilaha is, uh, is is it okay to say na kung tungod lang na naay na kanang common siya, then associated na gyud siya? So we need a proper means of measuring the strength of association. And that is already with your kani, relative risk and with your odds ratio. Next is your dose-response relationship. Now, as a dose of exposure increases, the risk of disease also increases. When we talk about dose or response relationship, mura lang po ni siya og in terms of saying na unsa ka grabe ang imuhang exposure ato na certain factor. And syempre, the more ka exposed, the more increases ang chances na magkaroon ka ato na condition. So let us take a look at this graph. Diba? This figure 4-1 is an example of a dose-response relationship in terms of the number of packs of cigarette smoked per day and in terms of lung cancer deaths per year. So, unsa inyuhang napansin? The more na increase, 'di ba? The more na daghan ka og packs of cigarette na gina-smoke per day, the more ang chances of getting lung cancer. Siyempre, kung ikaw, wala gyud, then, di mo gyud ka, most probably, di mo po ka magkalang cancer. So, that is what dose-response relationship means. Next is the replication of the findings. Now, if the relationship is causal, we would expect to find it consistently in different studies and in different populations. Now, replication of findings is particularly important in epidemiology. If an association is observed, we would also expect it to be seen consistently within subgroups of the population and in different population unless there is a clear reason to expect different result. Mura lang good pod ni siya og kanang sa inyong research study. Siyempre, di ba, para sure ta na kanang inyuhang experiment na gibuhat kay effective yun, di ba ginatry ba nato na siya og repeat. And if after the many times na na-repeat ninyo siya, the result is still the same, then that would mean effective yun ang atong gibuhat. So, murag ingani lang po na sa replication of findings na it should be consistent even in the different studies and even in the different population. Next is biologic plausibility. Now, biologic plausibility refers to the coherence with the current body of biologic knowledge. We seek consistency of the epidemiologic findings with existing biologic knowledge, and it asks the question, is there a biological mechanism by which the supposed cause can induce an effect? This simply means that no matter what association or how strong the association is, it has to make sense biologically to be considered causal. Diba? Dapat i-relate gyapon nato siya or kumbaga murag dapat na gyapon tay scientific explanation ani. Diba? Dili ta pwede mingon na pag kaning iro mamaak kay pwede ta mo bright. Murag unsa man nimo ang scientific evidence with that. So that is what biologic plausibility means. So one example is the observation or study that Percival Pott uh, na kanang iyahang gibuhat or na-discover. Actually, Percival Pott was the first person to discover the first occupational disease, and that is what we call your chimney sweep's carcinoma. Percival Pott observed that scrotum cancer is always present or naagyud siya or magka-scrotum cancer gyud tong mga chimney sweeps. When we say chimney sweeps, these are persons who clears ash and soot from chimneys. Now, diba murag mawirduhan mangyud ka na scrotum niya, nagalimpyo lang man siya og chimney. Unsa ang relationship? Is there a biologic explanation to this one? So, when I tried to search kung unsa jud ang underlying pud ani na or unsa jud ang scientific na reason for this nang ano magka-scrotum cancer man gyud kaning mga chimney sweeps, it is actually because of the exposure of that soots and ashes na because grabe sila ka-expose ana na ay warts daw na ma-produce. And ang kanang warts later on mag-develop into cancer. Diba? Na makakos man gud daw og irritation pud yung mga soot particles dira sa chimney causing warts and then warts causing or developing into cancer. So that is what biologic plausibility means. Na dapat naatay again scientific explanation to what is happening. Next is consideration of alternate explanations. Now, even if the presumed causal factor is associated statistically with the disease and occurs before the disease appears, it is necessary to show that there are no other likely explanations for the association. Now, as an investigator, especially when we are trying to look at what are the causes of the certain disease, dapat i-take into consideration yun nato na basig na apay other causes pag yun da isayaha. Let us not assume na isa lang yun na ang solely na cause ani na outcome. Tanawo nato from different side na basig na apog yun di ay alternate explanation as to why this certain outcome is happening. Na although lisod man gyud kaayo ni i-eliminate na kaning mga alternative explanations, but then again, kung naamantay makita ng mga new explanations, at least naka na makarule out pud tagamay or basi daig maka-strengthen pag yun siya sa katong first na cause na ato ang nakita. Kaya basta ang ato alang man diri kay kung wala gyud laing alternate explanation na, then pwede gyud ta mo conclude na mao gyud na siya ang ato ang cause. So let us take for example cholera that happened in 1849. Di ba pinaka-famous biagud kaayo ni siya na example. Now, before germ theory, which is until now, maumang yun na siya nga to ang ginagamit na or ginabasehan na theory, there was this what we call miasma theory. So what is this miasma theory? Cholera was caused by miasmas or noxious vapors which have their highest and most dangerous concentrations at low elevations. Remember that during the cholera outbreak in 1849, diba, tungod ba ito siya sa well na because of heavy rains and then naapadyoy katong animals na nasa isa ka side na ang katong water na ni run from that certain area and then padulong dito sa well so mo na contaminated si well. So kaning miasma theory, the true reason as to the association between cholera infection and the elevation was that, 'di ba, the higher the elevation, the less likely man gyud na ang wells mahimong infected. 'Di ba? The problem lang man ato na time ka ang well na mismo sa ubos. And then naa pa gyud sa higher na area ang katong mga animals, katong mga animals or cows ba to siya na maong na pag wash off or pag heavy rain tanan tubig dito na contaminated na adto pud sa inyong well. So that is why, as mentioned, the higher the elevation, the less likely that wells will be infected by water. And of course, the less likely that would people use river water for drinking. So, mo ni siya inyo makita actually ani na graph. Diba na raw? Elevation and then cholera death. And diba, the more increase ang elevation, the more na nagless ang cholera na death na nahitabo. Now, with regards to this one, actually dili nato pwede 'di ba i-cancel out yun si miasma theory during the time. Since 'di ba dili pa man gyud or wala pa man gyud tay other kanang wala pa man gyud tay means to discover what is really the cause of cholera during that year, 'di ba 1849 pa biya na siya. Then miasma theory was accepted. But by this time around, iba mo na ni ato ang alternate explanation since ni-enter naman ang inyuhang germ theory, then by this time around, nawala na gyud ni inyuhang miasma. So this is again about considering if there are other alternate explanations pa to really conclude that your association is really the cause. Next is cessation of exposure. Now, if a factor is a cause of a disease, we would expect the risk of the disease to decline when exposure to the factor is reduced or eliminated. Siyempre, in terms of cessation of exposure, this could really provide a very helpful supporting evidence for us to conclude that there is a causal association. Na kumbaga, if we try to remove that exposure, mo decline pud ba ang number sa nagkaroon ana na outcome? So try to look at this graph. This is actually in relation also to smoking and lung cancer. Basig matingala mo na pabalik-balik lagi ang example. Actually, kani manggod ang pinakadali gyud pud kaayo na ihatag na example. So as you can see, the longer the number of years na nag-stop og smoking, mga tao, iba na kunwari, after 5 years, ingani na ang number of people na nag-stop og smoking hantod sa, din nag-decline pud ang annual death rate due to lung cancer. Of which, we could actually conclude na strong na association yun si smoking sa lung cancer. Or, let us take another example. Now, this graph actually represents the epidemic proportion of the disease EMS or what we call eosinophilia myalgia syndrome. Actually, you could also try to look up your reference book which is si Gordis. I think kay Gordis na ako nagikuha. Now, with regards to EMS, there was a sudden, diba, as you can see here, sudden rise in the number of cases of EMS starting here, kanina from mga June to July until October. Now, the syndrome was found to be associated with manufactured preparations of your L-tryptophan. That is why, by November, so as you can see here, by November 17, 1989, the U.S. Food and Drug Administration recalled all L-tryptophan, all over-the-counter preparations of L-tryptophan, and then, as you can see, at a later parts of November, And then by December to January, na-observe nila na nag-decline na ang number of those individuals getting EMS. So in short, we could actually conclude na katong yun di ay ang problem, katong L-tryptophan na gina-prepare and gina-intake sa mga individuals. Diba? Adding the strength of causal inference regarding exposure. Next is consistency with other knowledge. So if a relationship is causal, we would expect the findings to be consistent with other data. So let us take a look at this one. This data is actually with regards to lung cancer rates in men and women and cigarette smoking in men and women. Now, as you can see, di ba consistent kaayo ang direction sa curves with the increase in lung cancer rates following the increase in cigarette sales for both men and women. Di ba consistent yun kaayo siya? Increase, ay increase, increase, increase. So, these data are consistent with what we would expect if the relationship between smoking and lung cancer is established as a causal one. So, actually, consistency with other knowledge, medyo, medyo related to katong sa isa nato ka guideline na katong replication na if ato siyang tanawon pud sa other subgroups pa, dapat consistent na naga-increase gyud or naagyo ni na certain exposure. Next is the specificity of the association. Now, an association is specific when a certain exposure is associated with only one disease. And actually, in terms of this guideline, this is, take note, siya ang weakest. Specificity is the weakest of all the guidelines and should probably be deleted from the list. Why? Since, diba, sa katong mga examples pa lang na ako ang gihatag, it is very rare na makakita mo na kanina exposure, dito lang yun na imo na siya ma-observe sa isa ka disease. Siguro ang isa lang na ako ma-point out na naiing ani na ingana ka specific in terms of the exposure and disease is genetic problems. Di ba na kung wala jud ka ani na gene or na ay gene mutation, then naagyud na always ang kana na sakit. Even smoking gani dili biya jud na siya totally dili biya na siya nakanang kay lang cancer lang yun. 'Di ba? Smoking kay pwede biya pud na siya maka-cause og pancreatic cancer, pwede na siya magka-heart disease and other conditions pa. So that is why specificity is considered as the weakest guideline. But kanilang po, when specificity of an association is found, it provides additional support for a causal inference. However, as with a dose-response relationship, absence of specificity in no way negates a causal relationship. Dili pod tungod dili siya specific agad-agad na ato na dayong i-cancel na dili na gyud siya ang cause. So, as explained a while ago, daghan ta og factors na maka-cause ani na disease. So that is why siya ang least likely, kanina guideline yun ang least likely na ato ang tan-awon. Now, as to this one, we'll be placing this one sa inyuhang handout and we'll leave this one for you to read. Try to relate the different guidelines that we have discussed in terms of kanisha. Diba? This is actually the assessment of the evidence suggesting Helicobacter pylori as a causative agent of duodenal ulcers. And that each of the guidelines we have discussed gisummarize diri ana box. So again, dili na lang nako na siya isang-isahon. Kamo na bahala magbasa and then kamo bahala synthesize. Kung unsa ang inyong na-learn dito sa akong discussion, I try to relate it to this one. So now we go to the common pitfalls in causal research. So these are actually the common pitfalls in causal research Natay lima. Bias, random error, confounding, synergism, and effect modification are also known as your interaction. Now, as you can see here in this box, natay definition, or di lang po na ako na siya isa-isahon, since along the way, ako alam po gahapon ni siyang i-discuss pa further and i-define. So, let us proceed. Starting with bias. Sa mangyudning bias. Bias is actually also known as differential error, in which it is a dangerous source of inaccuracy in epidemiologic research. Bias becomes a problem when it can weaken or it weakens a true association, it produces a false association, it distorts the apparent direction of the association between variables, and in terms of bias, it actually produces findings consistently distorted in one direction sa atuang o in one direction sa atuang graph or sa atuang research as a result of non-random factors. Imagine your everyday life. Diba, murag mao man na ang isa sa ako ang best example na mahatag. Diba, even in our daily life, we tend to be biased from the food that we eat, na naatay ato ang kanyang-kanya na preferences, that is already bias. So, there are actually two categories about bias. So, we have assembly bias and we have detection bias. So, starting with assembly bias, diba, in making a research study, but the very first step that you do is to find participants and then assemble them into groups. That is actually what assembly bias is referring in terms of your study participants. Now, first is your selection bias. Under assembly bias is your selection bias, which results when participants are allowed to select the study group they want to join. And this may be found in studies of treatment methods for terminal diseases and may result from non-response to potential study participants. Now, dili ta sugod sa kaning may be found in studies of treatment methods for terminal diseases. Diba? If you are a severely ill patient, usually kana or kita mangyud kita na mga severely ill patients, we are the most willing to try a new treatment. Even if known or unknown ang dangers ana niya, willing yun kita na mag-participate. Now, because na naay self-selection na nahitabo, a new treatment might be given to the patients who are sickest. And diba usually those who are sickest, most likely sila man yun ang naay relatively poor na results. And these results could not be fairly compared with the results among patients who were not as sick as those who are severely ill. That could already cause a bias. Another is kanisha may result from non-response to potential study participants. Selection bias may result from non-response of potential study participants, like for example, if we are trying to study possible relationships, exposure and disease outcome, and the response rate of your subjects is higher in people with the disease who were exposed than in people with the disease who were not exposed. So, ang tendency ani, ma-assume na hinuon nato na nay association even if wala gyud association. Kay diba? Again, ang mas daghan man og nag-respond dito sa exposed compared to wala. So, nanaday na inaccuracy na mahitabo sa ato ang data. Next is the allocation bias. Now, allocation bias is defined as a bias that arises from a systematic difference in how participants are assigned to treatment groups and comparison groups in clinical trials. Now, it may occur if investigators choose a non-random method of assigning participants to study groups, and it may also occur if a random method is chosen but not followed by staff involved in conducting clinical trials. Now, allocation bias, from the word allocation, it specifically relates to how your participants are allocated to groups. Sa selection bias, we're actually looking at the participant, na di ba na ay self-selection na mahitabo. With the allocation bias, we are actually looking at the investigator itself. Na di ba? Murag ang possible na bias na mahitabo manggo diri is ang kanang kita mismo giunsa nato pag-allocate, giunsa nato pag grupo-grupo ang kaninang mga certain individuals. Now, it may result if investigator know or predict which intervention the next eligible participant is supposed to get. Diba? And kanina knowledge, it may actually influence the way the investigators will approach potentially eligible participants and how they are assigned to the different groups. That is why, to prevent this allocation bias, ang best yun na buhaton ani is randomization yun. Dapat naka-random and dapat kung pwede gani dili po jud kabalo ang inyo ang investigator as to how you were allocated. Next is the detection bias. Now, detection bias may be the result of failure to detect a case of disease, a possible causal factor, an outcome of interest. Now, it may also occur if two groups of study subjects have large differences in their rates of loss to follow up. Kaning loss to follow up, actually, kani man yun ang isa sa common na problem yun. Labi na ko ang mga studies is in terms of uh, kanang it will take how many months or years kanang mga prospective na mga cohort studies kana sila kaya ang tendency man good usahay di ba dili na basig mahimong unresponsive na ang patient dili na nato makita or it could be na kanina certain na participant kunwari nagpuyo pa og Davao nibalhin og lain na place so kana na siya ang lisod and ang tendency na dili na pud nga nakanindot ang ato ang research study so that could still be under detection bias. Detection bias, just to add lang po day, detection bias could actually occur in relation to the loss of follow-up. Kay basi manggod ang katong mga na loss to follow-up, actually sila po unta to ang naay gwapo na response or gwapo na result or basig or but then again kay tungod kato lagi dili na nato sila makita then it could create such bias. And with the detection bias, under it is the measurement bias. So it may occur during the collection of baseline or follow-up data, and it may result from something as simple as measuring the height of patients with their shoes on, which case all height would be too large. So from the word itself, measurement, so kana na siya. Even kana palamang ganing pag simple measurement lang na lahi-lahi ang tools na inyuhang gamiton maski na kanang same good siya na inyuhang ginatry og kuha na measurement that could already cause a measurement bias or even in terms of kanang mga kunwari mga laboratory test measurement bias could occur if again there is inconsistency in terms of how you measured that certain test. Another is your recall bias. Recall bias may occur if people who have experienced an adverse event, such as disease, are more likely to recall previous risk factors than people who have never experienced that event. Now, recall bias is a major problem actually in research into causes of congenital anomalies. It results if members of one study group are collectively more likely to remember events than the other study group. Diba? Again, from the word itself, recall, meaning kung unsa to inyuhang ma-remember. And syempre, dili man gyud all the time, o di man gyud nga naka-perfect ato ang memory. It could be, na labi na, kunwari, ikaw na klase na tao, naga-take notes, gyud ka, then mas increase yun ang chances for you to recall such information. Unlike sa katong uban na murag wala lang, then kato sila, by the time na interview nimo, then most probably na-adyo din sila yung mga informations na dili nila ma-recall and dili nila ma-inform sa imuha. Then that is recall bias. Now, this is just an additional na type of bias which is your information bias. Now, this can occur when the means rather for obtaining information about the subjects in the study are flawed so that some of the information gathered regarding exposures and or disease outcomes is incorrect. Now, information bias could actually introduce misclassification bias. Misclassification bias meaning inaccuracies in methods of data acquisition which may lead to misclassification of subjects. Like for example, you are trying to group people as to, di ba, sa case control na kanang study. So, nagatry ka gather of people na katong mga na-ay disease and katong mga walay disease. Now, if mali ang information na ilang nahatag, then ma-misclassify ninyo sila. So meaning, instead na wala gyud unta sila sakit, gibutang ninyo sila dito sa naay sakit. Or katong mga walay sakit, gibutang po ninyo sila sa or katong mga naay sakit, gibutang po ninyo sila sa walay sakit. Or pwede po another possibility is with regards to misclassifying a person's exposure status. Diba? Believing that the person was exposed, na wala man gyud unta siya na-expose, or believing that the person wala na-expose, pero in fact, na-aggrade siya exposure. So, kani sila na misclassification bias, magdepende man gyud siya again sa information na ihatag sa inyuhang participant or patient. Now, in terms of the information bias, there are actually several types and sources. And actually, under diri, as you can see, pwede ma-under po ang inyong recall bias diri. Since, diba, in terms of recall bias, it's a matter still of giving information. So, it could be bias in abstracting records. It could be bias in interviewing. It could be bias from surrogate interviews. Ang ginamin lang po aning bias from surrogate interviews. Like for example, katong inyuhang respondent or participant kay namatay, and since namoy gusto or kailangan nakuha na data, so ang inyuhang gipangutan is ang kinsa man ang dependent na available. So syempre namang gyud na siya inaccuracy kay dili man gyud na ma-recall sa kato siya na individual ang tanan sa kung unsa may nahitabo atong imuhang respondent. Then we have surveillance bias. Now, surveillance bias is actually a type of information. It occurs when one group of subject is followed up more closely than the other. What does this mean? For example, ato ang ginatry og sadihan diri is the relationship of oral contraceptive use with thrombophlebitis. Now, by the time na nagpatabang ka sa physicians, mga different physicians, mag-increase nun ang tendency na mas ginamonitor sa physician ang katong mga patient na naay na ginaprescribe nila og oral contraceptive than those who do not. So, unsay mahitabuan ni ron? So, as a result, uh, physicians would be more apt to identify cases of thrombophlebitis that develop in those who are using that oral contraceptive than among those patient na nagka-thrombophlebitis gihapon pero wala na take ato na oral contraceptive. So that is surveillance bias. Again, mas gina-follow up nato more closely ang katong ato ang subject than katong dili involved. Then, na-explain naman ni si recall bias. Then we have kaning last, which is the reporting bias. With reporting bias, this is actually in terms of the subject or your participant being reluctant or dili kay siya gusto mo report sa exposure. It could be because kanang kumbaga basig kay aware siya daan sa attitude or naa siya mga certain beliefs or mga certain perceptions, so kana still bias under gihapon na siya sa information bias. Next is random error. Now, random error is also known as a chance error or non-differential error. Now, it produces findings that are too high and too low in approximately equal amounts. Usually less damaging ni siya than bias because it is less likely to distort findings by reversing their overall direction, and it decreases the probability of finding a real association by reducing the statistical power of a study. Now, random error, no, sa pangalan pa lang, it is random in nature and very difficult to predict. Now, it occurs because there are a very large number of parameters beyond the control of the experimenter that may interfere with the results of the experiment. So, to give you a concrete example, kunwari kita sa laboratory, kita na microbiologist, di ba? Or kanang kunwari kita na assign ta dito sa mag-culture og bacteria. Now, the reproduction of a particular strain of bacteria na katong gusto unta nato i-culture might encounter this what we call random error due to, di ba naman dyan ay slight variation sa temperature ba or sa light sa room, ah, na ay katubang ato ang agar na gibuhat na apoy slight difference sa pagkabuhat yesterday than today. So mga nga na siya. But however, when the readings are spread over a period of time, we can actually get rid of that random variation by averaging out our result. So kana lang po na ang sa inyuhang random error. Next is confounding. Now, confounding comes from the Latin roots meaning to pour together, and this is a third variable that influences both the independent and dependent variables. Now, the problem with confounding is that it can actually obscure a true causal relationship. Failing to account for confounding variables can cause us to wrongly estimate the relationship between our independent and dependent variables. So basically, there are two major problems when confounding is present. First, it could increase variance, and second, it could actually also introduce bias. Confounding, nani siya hidden effect gyud sa atuang outcome. So, how would we know if it is a confounder? If it is a known risk factor for the disease, and second, if it is associated with the exposure, but is not a result of such exposure. So, to give you an example, kunwari, the percentage of gray hairs sa atuang head of adults is associated with the risk of myocardial infarction. But presumably, that association is not actually causal. Diba? Actually, confounding na mention na nako kaganina na under ni siya sa inyuhang non-causal association, not unless proven na causal yun siya. But if there is really a confounding variable which is our third variable, then the association is that is present is actually non-causal. And diba, nakatagma ko atong example regarding baldness and CHD, so mura lang po kani, na in terms of the percentage of your gray hair, naga-increase, and it is associated with the risk of your myocardial infarction, diba, si gray hair, pag increase sa numbers inyong gray hair, di man yun na siya mo ang cause na nga nag-increase inyong risk sa myocardial infarction. Nga mo nagka-gray hair, it's because of the age itself. And even risk of myocardial infarction kids, in which in layman's term kaning myocardial infarction is known as heart attack, diba? Increase man pud na ang risk as we age. So meaning, our confounder there is actually the age. So we need to consider that one. So let us take another example with regards to coffee, relationship between coffee and pancreatic cancer. Now, it was observed that there is an association between drinking coffee and pancreatic cancer. However, as the study goes, diba na sila nakita na confounder which is smoking. Because, going back, na para again makaingon ta na confounder siya, diba unsa tong first na criteria nato, dapat known risk factor siya. And smoking is actually a known risk factor for pancreatic cancer. Second, para makaingon ta na confounder siya, di ba dapat associated siya with the exposure, pero dili niya ginakos ang exposure. Smoking is actually associated with coffee drinking, but di ba dili man na siya mao ang result kung ano naga-drink yun og coffee. It's just that it is actually very rare to find a smoker na wala naga-drink og coffee. Di ba? As a person or as an individual, we are really fond of drinking coffee. Diba? Parents pa lang gani ninyo, magsige mag-inom og coffee. So, all the more, na mauna na associated si smoking with coffee drinking, though non-causal ang association, pero again, they are related. Now, ang atuan diri karon, kung ang association bagyod na observed between coffee drinking, kani association observed between coffee drinking to pancreatic cancer, kay causal, or that the observed association of coffee drinking and cancer of the pancreas, it is because of the presence of this confounder. So, muna siya ang atuang ginatry diri og tan-aw. Now, there are actually three types of confounding: the negative confounding, the positive confounding, and the qualitative confounding. For the negative confounding, it is when a third variable masks or weakens a true association between two variables, meaning it underestimates the effect. Positive confounding is when your third variable produces an association that does not actually exist. In other words, it actually overestimates the effect. Now, with regards to qualitative confounding, it is when your third variable causes a reversal of direction of effect. And to give you a, more examples pa with regards to negative, positive, and qualitative confounding, na ako'y video later, but before that, take note that neither type of confounding is a good thing. Dili kay pas tungod mo yung tag-positive, okay na siya. Again, di ba, as mentioned, it overestimates your effect. And sometimes, it says na ay association when in fact wala. So, neither is a positive factor. Both are bad and negative in terms of effect. So, meaning we need to prevent confounding in terms of our study. Namonito siya akong video na ginaingon, tanagan dili na lang nako siya i-play diri i-upload na ko ni siya separately sa Canvas for you to watch later on. So, proceed na lang punta sa ato ang discussion. Actually, kato na part again, explains further positive negative confounding. So, how to exclude or control confounding? So, natay upat. It could be through randomization, through restriction, through matching, and through stratification. Now, in terms of randomization, if a large number of subjects are allocated to your treatment groups by a random method, that would actually give an equal chance of being in any treatment group, whether or pwede po na because of such randomization that you are doing, it could or it would most likely nakatong paggrupo nimo na ay similar distribution in terms of age, gender, and behavior. Randomization actually controls for both known and unknown confounders. Kay kanilang po na siya. Confounding actually occurs if there is an equal distribution among your groups. Sumuna na ang next nato na buhaton to control is through restriction. Now, restriction means limiting the study to subjects in one category of the confounder as a simple way of ensuring that all your participants have the same level of confounder. So, for example, if nakita nato, like for example nato kaganina, di ba na ang atuang confounding factor is smoking, pwede nato i-limit ang atong study population to only non-smokers or only smokers. If ang sex kay confounding factor, then pwede po nato siya i-limit na ang atong participants pa kay men lang or babae lang. Diba? Again, restriction. If age ang confounding factor, then pwede ta mag specific age category. So, pwede nato i-restrict na ang atong participants kay dapat na alang sa 10 to 20 years old, na alang to 56 years old. That is restriction. Next is matching. Matching, very ginagamit actually ning matching labi na if we talk about kanang mga case control studies or cohort studies na kumbaga from the word itself matching, kung naatay participant na smoker, i-match nato siya sa wala naga-smoke. Kung naatay participant na active, physically active, i-match nato siya sa dili physically active. So, muna siya ang ginapasabot sa matching. And then last is stratification. When we say stratify, diba, it means to arrange or classify. Now, isa ka example aning mag-stratify. Actually, halos the same ni siya with restriction, pero kani classifying different groups lang po. Like for example, we are trying to stratify data by degree of urbanization. So, na rural, na urban, so yung ana. So, that is also another way of confounding na kumbaga, if the relationship, balik na punta dito sa inyong lung cancer ug smoking, na if ang relationship sa inyong lung cancer ug smoking is really due to smoking and not to the confounding effect, na kunwari, consider nato in relation nato mag-stratify ta sa degree of urbanization, uh, dili siya, effect sa confounding na, for example, si pollution ang atong confounding or urbanization, then, each atong stratum sa atong urbanization, the incidence of your lung cancer should be higher in smokers than in non-smokers. So, kana lang. Take note of this one in terms of excluding or controlling confounding. Next is synergism. Actually, daghan kayo og research studies about synergism. So, unsa dining synergism? It comes from the Greek roots meaning work together, and it is the interaction of two or more presumably causal variables so that the combined effect is clearly greater than the sum of the individual effect. So, try to look at this graph. Diba? Relationship between percentage of low birth weight infants and number of adverse factors present during the pregnancy. An example of an adverse factor here is kunwari teenage pregnancy, maternal smoking, or kanang alcohol drinking, or kaya drug use, so kana na siya. And as you can see here, the more nadaghang combination sa adverse factors, diba, the more ang chances na low ang birth weight sa tuwang infant. So, mo siya ang ginamin aning synergism. One adverse effect alone, dili nga nakadako og impact. But when we are trying to combine, then the more po na naga-increase ang iyahang effect. Next is effect modification or interaction. Now, unlike confounding, kaning effect modification, it is a biological phenomenon in which the exposure has a different impact in different circumstances. So, to further explain, effect modification is actually the term used by epidemiologists, but when you are a biostatistician, interaction is what we use. Now, it occurs when an exposure has a different effect among different subgroups, and it is associated with the outcome rather than the exposure. So, to give you an example, EBV, your Epstein-Barr virus infection manifestation in different geographic areas. Kumbaga, EBV actually results in what we call your infectious mononucleosis. But actually, in terms of geographic areas, it was found out na kanang infectious mononucleosis that is actually observed only in the United States. But when you go to the African regions, dili infectious mononucleosis ang inyuhang ma-observe or ang outcome, but ang actually ma-produce is what we call the Burkitt's lymphoma. Diba? That is effect modification already. Different effect among different subgroups. Are we looking at the exposure? No, we are actually looking at the outcome. Another example is hypertension among white men and women in the United States. Na nakita lang po diri na ang rate daw sa increase sa inyuhang blood pressure nagdepend po siya sa gender. So, muna na naapoy effect modification in terms of hypertension. Dili lang sa age, kung dili pati sa gender na mas ah sa tawagan ni mas daghan sa white men ang naay hypertension, especially as they age compared to women. So, that is all the common pitfalls with regards to causal research. So now we go to the last part of our discussion, and these are just some important reminders about risk factors and disease. Na kumbaga, just to sum up all of those things. So one causal factor may increase the risk of several different diseases. 'Di ba? Like for example, kato atong dimension regarding cigarette smoking being a risk factor not only just for lung cancer, but it can also be for your pancreatic cancer, even your COPD, your chronic obstructive pulmonary disease. Next, one disease may have several different causal factors. Like for example, katong COPD na atong gimension, your chronic obstructive pulmonary disease. Smoking is one causal factor, but actually it is not exclusive to that. Pwede ka magka-COPD kung exposed po ka sa mga dust like kanang mga coal dust, mga silicone, or COPD could actually also be caused by a genetic factor. Now, the possibility of confounding and effect modification often makes the interpretation of epidemiologic studies difficult. Age, whether young or old, may be a confounder because it has a direct effect on the risk of death and of many diseases, so its impact must be removed before the causal effect of other variables can be known. Advancing age may also be an effect modifier because it can change the magnitude of the risk of other variables. Diba? Nanabi tayo mga na-example ani with regards to age, with regards to young or old ba siya na possible confounder gyud or labi na kaning advancing age kay syempre with age lahi-lahi namang gud na ang ato ang kumaga body system, 'di ba? Like for example, kung old na ka, then ang mong immune system ana dili na gyud nga na as good as sa mga batan-on pa. So that is why age being a common confounder, again, going back sa katong gidiscuss nato, then pwede gyud nato na siya i-restrict. So this is just a summary to all that we have discussed. Dili man gyud na ko ni isa-isa hunog basa, na lang po ko'y gusto i-emphasize with regards to this one. Now, actually, in a causal research, validity should also be present. And we have this what we call internal validity. This one, internal validity. And naputi ginatawag na external validity. So let me just define each. Internal validity defines whether a study's result may be trusted. Siyempre, ang atong research study, dapat na amang yun ni siya. And even the external validity, which defines the degree to which the result may be considered relevant to individuals other than the study participants themselves. Dili ta pwede magpataka lang og buhat og research sa study without these two validity. So always consider both internal and external validity. So that ends the first part of our lecture. You may take a little bit of rest and then proceed later with our second part. Thank you.